Imagine walking into a hospital. There's this fundamental tension, isn't there? How do the staff keep a patient safe, maybe from themselves even, but also respect their freedom?
Yeah, it's a really tough balancing act.
And today we're doing a deep dive into exactly that, focusing on restraint use. Now, in the Netherlands, where this story is based, that means basically any intervention that restricts a patient's personal freedom.
And it's so critical we talk about this because, look, sometimes restraints are necessary, absolutely. But when they're not used right or maybe not documented properly, the harm can be quite severe.
Harm, like what specifically?
Well, you can see things like pressure ulcers, patients getting more agitated, confused. It can even lead to them staying in the hospital longer.
Mm.
And the big issue, the one this project really tackles, is that the documentation, it's often just missing
Mm.
or inaccurate.
Okay, so that's our mission today then. We're going to unpack this really interesting quality improvement project from a Dutch academic hospital, Maastricht UMC plus Hospistry. They faced this exact documentation issue head on.
And their approach, well, it led to some pretty eye-opening results.
So let's get into the core problem they had. They had protocols, right?
Mm.
Procedures were supposedly in place.
They did.
But they found the actual documentation for restraint use was, and this is startling, basically 0% correct.
Zero, yeah.
Which means they couldn't reliably know when restraints were used, why they were used, how.
Yeah.
Nothing.
Exactly. No real oversight possible, no way to learn or improve systematically.
So starting from absolute zero, what was their game plan? How did they approach this?
They used a structured method, 3 cycles of Plan to Study Act, or PDSA.
Right, PDSA, plan it, do it, check it, adjust it. That iterative cycle.
Precisely. And crucially, they brought together a multidisciplinary team, doctors, nurses, but also, importantly, patient representatives.
That inclusion feels key. So PDSA cycle 1, what was the first do?
The first big step was actually quite straightforward, conceptually at least. They implemented a new detailed documentation form, one for every single time a restraint was used.
Just having the form.
And the impact, immediate. And pretty remarkable, actually. Correct documentation jumped from that zero baseline to almost 58%.
Yeah.
57.8 to be exact.
Wow. Just from having a clear tool.
It seems so. It suggests the will was maybe there, but the means weren't clear or easy enough before. It created the capacity, you know.
Okay, but 58% isn't 100. They didn't stop there. PDSA 2.
No, they pushed further. Cycle 2 was this multifaceted intervention, a real mix of things.
Like what?
They had a hospital-wide theme month just focused on restraints, raising awareness. A new interdisciplinary protocol was rolled out. They put QR codes on the restraints themselves.
Oh, smart. So staff could quickly scan for instructions.
Exactly. Quick access to application guidelines. And then the really creative part, an escape room.
An escape room, seriously, in a hospital.
Yep. Designed to help staff practice their knowledge and skills around restraints in a more engaging, maybe even fun way. Less like a lecture, more hands-on.
That's brilliant. Active learning. Okay, and then cycle 3.
Cycle 3 was about closing the loop. They provided very specific, targeted feedback on the documentation data, right down to the departmental level for nursing and medical teams.
So reinforcing the importance, showing them their own data.
Exactly. Making it visible and relevant to their daily work.
Okay, let's pull back and look at the big picture then. The cumulative results.
So ultimately, they stabilized with correctly completed forms around 55.9%. Still a huge leap from zero.
Definitely.
And they also saw improvement in documenting restraints borrowed from the medical equipment department. That went up from about 38% to 51%.
And beyond just the numbers on the forms, what else did they notice?
This is maybe the most fascinating part. Just improving the documentation seemed to increase awareness significantly. And the data indicated a reduction in the use of the most severe types of restraints, Category 5.
So transparency itself started to change practice.
It seems that way. When you measure something, when you make it visible, people pay attention. It likely prompted more reflection on whether restraint was truly the only option.
Makes sense. Were there challenges along the way? It couldn't have all been smooth sailing.
Oh, for sure. One major issue they flagged is the lack of a standard global definition for restraint use. It makes comparing data between countries, even between hospitals sometimes, really difficult.
Yeah, I can see that.
And there was a slight hiccup, a lesson learned. At one point, they temporarily took the restraint data off the main nursing dashboard.
Why?
Unclear from the source, maybe technical reasons or streamlining. But the effect was it risked signaling that restraint monitoring was less important. They realized they needed to keep that data visible to maintain focus.
Right. Visibility is key for sustained improvement. So what's next for Maastricht UMC plus Go? Are they building on this?
They are. For 2025, they're piloting a new role, restraint nurse consultants.
Interesting. What will they do?
The idea is they'll proactively visit patients who have higher category restraints applied, offering expertise and support.
And technologically?
By the end of this year, 2024, the plan is to fully integrate all this restraint data into their main electronic patient record system, the EPR.
Which should mean even better, more seamless monitoring and documentation going forward.
Hopefully, yes. Much more embedded in the workflow.
So when you step back, this deep dive really highlights something powerful, doesn't it? Improving what might seem like boring admin documentation can actually have this really profound positive effect on patient safety and the quality of care.
Absolutely. It's proof that focused, meticulous improvements can genuinely shift outcomes from 0%. That's quite a journey.
It really is.
And it leaves you with a thought, doesn't it?
Yeah.
If getting documentation right here for restraints boosted awareness and potentially reduced their use, what if we applied that same rigorous focus on clear, consistent documentation to other critical areas in healthcare? Think about routine procedures, medication administration, handovers.
Could that kind of transparency revolutionize the patient experience, improve safety, and maybe even outcomes on a global scale? What else are we missing simply because we aren't documenting it well enough?